Okay, we're going to get started in just a minute. So get settled and away we go in just a minute. Just a couple pieces of housekeeping. Someone had a good question that many people tend to have, which is, hey, do you have notes or slides that you can send us? And unfortunately, not for this lecture, because this is a free lecture, we do not include the slides. But if you do decide to join Archer and purchase a package, you'll be able to find this on demand and you'll be able to access the notes there as well. So you can access them if you do join Archer. The other thing I wanted to quick mention is I'm sure you guys are going to have questions during the presentation. Unfortunately, because there's so much stuff I have to get through today, I'm not going to be able to just pause and answer most of the questions, but we have someone here who is answering questions. What you'll want to do is just post your question in that question box, and we have another tutor, Rachel, who's wonderful, is here today, and she'll answer questions as you go. So don't feel like you can't ask questions. You'll just want to ask them specifically in that question box. All right. So again, for those of you who are just joining, my name is Elizabeth Diger, and I'm actually a women's health nurse practitioner. So I've spent about 10 years working with women, and I've developed a passion for maternity. But I'll be honest with you guys, before I took my NCLEX, maternity was one of the subjects I was most afraid of. But hopefully, for any of you guys who feel like, oh no, maternity, hopefully after today, you're going to feel more confident, because we're really going to try to cover the stuff that shows up most on the test. And if we're talking about maternity, you absolutely first want to study the symptoms of pregnancy. And we put these into three categories. There are the presumptive signs of pregnancy, there are the probable signs of pregnancy, and then there are the positive signs of pregnancy. First of all, let's look at the presumptive signs. So presumptive means probably they could be pregnant, possibly, but we're not sure 100%. And presumptive spells out the word presume. And basically, all of the presumptive signs of pregnancy are going to be symptoms that the patient has and brings to you. They're going to say, hey, my period's been absent for 3 months. And that should make you say, hey, possibly this person could be pregnant. And remember, a lack of a period for more than 3 months is called amenorrhea. If they're really tired, if they have enlarged breasts or sore breasts, probably those hormonal changes are causing those symptoms, but we don't know for sure until we do a test. Urinary frequency increase, that's a common first symptom in pregnancy that many women will have. Movement perceived is that first movement that women feel when they're pregnant, and that's also called quickening. Quickening is defined by that first movement you feel, typically somewhere between about 16 and 20 weeks gestation. And then also emesis and nausea. Again, those hormonal changes very often cause nausea and sometimes vomiting in pregnancy. So if a woman comes to you and she has any of these symptoms, you should think, oh, I presume she could be pregnant. Probable signs of pregnancy are the objective findings that the provider would see on exam. So what are some objective findings? Well, a positive pregnancy test, whether it was taken at home or in the clinic, it's probable that that person is pregnant, but we still wouldn't take it to the bank. It's still not 100%. The return of the fetus when tapped is called ballottement. That's basically when the provider is doing a vaginal exam and taps on the cervix. If the baby is big enough, typically not until the second or third trimester, what will happen is you'll feel the baby push away from your fingers, and then the baby will float back and tap your fingers again. That's ballottement. So if I was doing an exam and I felt that, I would say, oh, I think this person's probably pregnant. The outline of the fetus palpable by the provider, that's probable. Braxton Hicks contractions are those false labor contractions. A softening of the cervix is known as Goodell sign, and that cervix, because of hormonal changes, actually starts to soften very early. As early as 4 weeks pregnant, you can feel that cervix getting soft. The bluish coloration of the cervix is also known as Chadwick sign. That happens pretty early on too, as soon as 6 to 8 weeks pregnant, and that's usually because of the increased vascularization of pregnancy. There's the lower uterine segment softening. That's known as Hager sign, and that occurs also around 6 to 8 weeks pregnant. And then there's also the enlarging uterus. So all of these would make me say, I think this person's probably pregnant, but none of them are certain. You would still want to do further testing. The positive signs of pregnancy are the, yep, take it to the bank, this person's pregnant. And these are going to spell out the word fetus. So if you can feel fetal movement as the provider, that's a take it to the bank sign. Electronic device detection of fetal heart sounds. If you can get a Doppler heartbeat from the fetus, they're pregnant. Of course, the delivery of the fetus, that's a pretty sure bet. Ultrasound detection of the fetus, if we see that fetus on ultrasound, or if there's any seen movements by the provider. If you see a foot kick out in the abdomen and the provider sees that, that's a take it to the bank sign. And these, of course, spell out fetus. So let's try a question on this. This question says, a client presented to the clinic stating that her home pregnancy test was positive. The nurse understands that this is what kind of sign of pregnancy is this? This is the type of question they might ask you on the NCLEX. So let's just take, about 30 seconds. Tell me what you guys are thinking. And you can put your answer right in the question area. Once you have an answer, put it in the question box. And it's okay if you don't know for sure. You can just guess. These are hard questions. You're just learning right now. Good. A lot of you guys are getting this right. Good. Excellent. You guys are really impressing me. Ruth, yep. Angela, Anna. Hi, Anna. Good to see you. Good. Good. A lot of you guys got this right. This would be a probable sign of pregnancy. If we go back, remember the positive pregnancy test is a probable sign of pregnancy. They're probably pregnant, but we don't know for sure. So we still need to do further testing. Okay. All right. Next, let's talk a little bit about Nagels Rule. Let's switch gears a little bit. How do you figure out the estimated due date if all you have is the first day of the last menstrual period? You do need to know this because you can't guarantee you'll have an electronic calculator to calculate this at all times. You can't guarantee you're always going to have a pregnancy wheel. So you definitely want to know this formula. And basically the formula is you're going to take the first day of the last menstrual period, you're going to add 7 days, subtract 3 months, and add a year. And I actually do it right in those steps. So let's go ahead, let's do this first one together. And then the next one, I'm going to let you guys try on your own. So we have a last menstrual period of 10/25/2020. First thing I ask myself, okay, is there 31 days in this month or not? And this month has 31 days. So basically what you're going to do, you're going to take this and you're going to add the 7 days first. So 25, 26, 27, 28, 29, 30, 31, and 1. So that takes me to November 1st of 2020. Next thing I'm going to do, I'm going to subtract 3 months. So I'm going to go, okay, November, October, September, August. So August 1st, 2020. And then the very last thing I'm going to do is I'm going to add a year. So August 1st, 2021 is the answer for this question. So this one, let's do together. So we have a last menstrual period of 7/26/2020. And let me give you guys a clue. This month has 31 days in it. So go ahead and try. You're going to add 7 days, subtract 3 months, add a year. Tell me, what is this person's estimated due date? What are you guys thinking? And you can put that right in the answer or the question box again. Ooh, Jeanette, good job. This is a hard one. Laura, If you guys are struggling with this, the way I recommend you practice this is go ahead, find an online pregnancy calculator, and then go ahead and just do random questions. Pick a random date and do the formula on your own, and then double check to see if you got it right by putting the date in the pregnancy calculator. So just keep practicing this. The more you practice it, I promise the easier it will get. But at first it's tricky. So a lot of you guys are getting this right. This is a tricky one, and a lot of you are darn close. So, okay, we have 7/26/2020. First thing we want to do is we want to add 7 days. So we have 26, 27, 28, 29, 30, 31, 1, and 2. So we're in August 2nd of 2020. Next, we want to subtract 3 months. So August, July, June, May 2nd of 2020, and then finally we just add the year. May 2nd of 2021 is our answer. So again, these are tricky at first. Keep practicing them. I promise the more you practice them, the easier they will get. All right, this is just a very simple diagram of a baby or a fetus in utero. And real quick, I just want to remind you of the basic anatomy. Remember, women have an external vulva. They have the labia majora and the labia minora, and that leads into the vaginal canal, also called the birth canal. At the end of the birth canal is the cervix, which is the opening of the uterus. And the cervix leads into the uterus. The uterus is an amazing organ. It's an organ that grows all the way from the size of your fist to the size of a watermelon and back again. It's amazing. And of course, that's the organ the fetus grows in. Within that uterus, there's going to be an amniotic sac that forms around the fetus and protects the fetus, from trauma. Certainly, if someone gets punched in the stomach, that fluid surrounding the fetus would protect them. Then, of course, there's the fetus. The fetus has an umbilical cord, which is attached to the placenta, and the placenta, of course, attaches to the uterus, and that's where nutrients are exchanged. The mother sends nutrients through the placenta, through the umbilical cord to the baby, and the baby then sends the waste products back through that umbilical cord to the placenta to send out to the mother again. So it's really an amazing system. If you want a more detailed explanation of the anatomy, I definitely recommend you also watch the maternity video on demand if you're a member of Archer, but those are the basics. Next, I want to shift into the weekly developmental milestones in pregnancy. So first, let's talk about the first trimester. So the first trimester is really, during this trimester, a lot happens. A fertilized egg changes from just a small grouping of cells all the way into a fetus that starts to have a baby's feature. A lot of development happens in this first trimester. So let's go month by month. First of all, we have month 1. This is weeks 1 through 4. And really, this is the time where, a fertilized egg grows and a watertight sac forms around it, and that creates the amniotic sac. That happens really early. This is also when that placenta develops, and already a primitive face starts to form and the heart tube develops. Something that's interesting about that first month is there's something called an all or nothing effect. If someone were to take anything harmful during that first month, that happens pretty commonly. Say if a woman doesn't know she's pregnant and goes drinking with friends, well, what happens if she does that and she doesn't know she's pregnant? Well, it's all or nothing. Either the teratogen, the alcohol, was so damaging that it will cause a miscarriage, or nothing will happen, because at this point, none of the organs are developed. So it can't cause any harm to the organs directly. So either it's going to cause the pregnancy to end, or it won't cause any harm at all. That's the all or nothing effect. Month 2 is weeks 5 through 8. This is where the facial features continue to develop. A neural tube develops as well, and already at 6 weeks, a heartbeat can be detected on ultrasound. In month 3, this is weeks 9 through 12. After that 8th week, the developing baby is actually referred to as a fetus. On weeks 1 through 8, we call it an embryo. It's an embryo first, and then starting at week 8, it's a fetus. Hands, arms, and fingers and toes will be fully developed, and they're going to start to explore. They're going to open and close their fists. They're going to put them in their mouth. And by the end of that 3rd month, the fetus is really fully formed. All of the organs and limbs are present, but they're going to continue to develop and become functional over time. All right. And since most of the development has already taken place by the end of that 3rd month, the risk of miscarriage goes down significantly after that 1st trimester. So as long as you make it through that 1st trimester, your pregnancy has a good chance of continuing. Next, we're in the 2nd trimester. For most people, this is really considered the best part of pregnancy. For most, in that 1st trimester, pregnancy's hard. There's nausea, there's fatigue. You just don't feel very good. But in the 2nd trimester, you really start to feel pretty normal. In month 4, weeks 13 through 16, now the fetal heart rate is audible with a Doppler. You can first hear that possibly as soon as 10 weeks, but now it's really going to be consistently heard. Facial features really develop, and the nervous system really starts to function at that point. Month 5, weeks 17 through 20, the fetus is developing muscles, and they're exercising those muscles. They're developing hair, and lanugo, that fine hair on the body, begins to develop. Also, the skin becomes coated with vernix caseosa, which is kind of like a cheesy substance that coats the skin and protects it from the long exposure to that amniotic fluid. All right, then we have month 6, that's weeks 21 through 24. The eyelids begin to open. The fetus is really going to start responding to movement or even increased maternal heart rate. If born prematurely, the baby might survive if born after 23 weeks, but often these babies have a lot of health issues and they're in the NICU for a very long time. Then we have month 7, that's week 23 through 28. The fetus begins to develop body fat, hearing is fully developed, so you can sing and talk to your baby and they'll respond. The fetus is going to be changing positions frequently, so they're going to be punching around a lot and the mom might feel uncomfortable. And if the fetus is born after that 28th week, they're very likely to survive. All right, then we have the 3rd trimester. Most women, once they hit this 3rd trimester, they're pretty ready to deliver at this point. They're developing lots of aches and pains, especially in their joints, and they're definitely ready to go. So let's look at these months one at a time. First, we have month 8. That's weeks 29 through 32. This is where kicking increases, and there's definitely rapid brain development, and the fetus can actually see and hear quite well at this point. Month 9, weeks 33 through 36, the lungs complete their development after that 37th week. So that's why we call week 37 term, and week 40 is full term. 37 weeks is considered term because that's when all the organs, including the lungs, are fully developed. And really, there are coordinated reflexes, and the fetus becomes even more responsive to stimuli. Then we have month 10, and a lot of people are going to be like, I thought there were only 9 months. Well, despite what pop culture tells us, there are actually 10 weeks instead of 9, depending on when you count the pregnancy starting. But technically, there are 10 weeks of pregnancy, not 9. So weeks 37 through 40, this is the final month. Labor can happen at any time during that stage. Movement really starts to decrease as space runs out. And if the baby's not in the right position at this point, we're going to have a conversation about trying to shift that position, or potentially, we might need to deliver via C-section. Typically, we do not let the pregnancy go much further past about 41 weeks. After 40 weeks, the placenta actually will start to degrade, and over time, the risk of stillbirth goes up and harm to that fetus. So most clinics are not going to let a person get anywhere near that 42nd week. They're going to induce them before that, just to reduce that risk. All right, now let's shift gears again. What's nutrition in pregnancy that you as the nurse should teach your patient? Well, pregnant women have a lot of nutritional needs. Something that is not on this list that I want to comment on first is they need to stay well hydrated. The average adult, really should get, 8-ounce glasses of water a day, typically. That's usually the standard recommendation. So a pregnant woman at least needs that, if not a little bit more. So pregnant women should drink lots and lots of fluids to stay hydrated. But they're also going to need proteins, especially lean options are ideal, like white meats, dairy, eggs, those beans and legumes, nuts, soy-based products. Those are all going to be really important because they're needed for fetal growth, especially the development of the muscles and tissue. Complex carbs are also needed, especially whole grain carbohydrates. Beans and starchy vegetables are best. These are needed because they really give the mom that lasting energy they need. You do want to avoid simple carbohydrates in pregnancy, though, especially if you have gestational diabetes, and we'll talk about that more later on in the presentation. Fiber is important. This is a type of complex carb that's often found in plant-based foods and legumes, and this is needed for healthy digestion in pregnancy. Let me tell you, because of hormonal changes, peristalsis slows down in pregnancy. So a very, very common complaint is constipation. The two things I tell those patients to do: drink more water, eat more fiber. You really need a lot of fiber. And then finally, healthy fats are very important as well. This is very important for energy in the mother, and also for development of fetal organs and the placenta. So options like avocados, nuts, and seeds, all really good choices. Fish are also good, but only certain types of fish. You want to avoid fish high in mercury, especially those top of the food chain fish, the predator fish, like big eye tuna, mackerel, marlin, swordfish, shark, tilefish. Those are a no-no in pregnancy. Those have way too much mercury, which can affect development of the fetus. What you want to do is maybe 2 servings a week. You want oily fish like fresh tuna, mackerel, sardines. Those are good, but only 2 portions a week. And generally, pregnant women need about an extra 300 calories per day to support their growing fetus. We used to, way back in the day, say, oh, you're pregnant, you're eating for 2. No, you're not eating for 2, you're eating for 1 plus a fetus. So you really only need 300 extra calories a day. As the pregnancy continues, the caloric needs do go up with time. And just so you know too, depending on your starting weight, how much you take in extra changes. So for example, if you had a patient who started out with a very low BMI, someone who is underweight, I might have them take an extra 400 to 500 calories a day. They need to pick up that weight. Whereas most people fall into that overweight or obese category. And so for them, we would decrease the caloric intake. We would say maybe like 200 calories extra a day for them. There's also some additional supplementation that's needed. Definitely folate or folic acid, very, very important. This is typically in a daily prenatal vitamin, and it really, really helps to prevent birth defects of the spine and brain. And remember, let's think back to the weekly development of the fetus or the monthly development. When is that neural tube formed? Really early in pregnancy. So it's very important that women are taking folic acid at the beginning of their pregnancy. And that's why if I have a patient who's, someone of childbearing age who possibly could become pregnant, I'm going to recommend that she take a daily multivitamin with folic acid just in case she becomes pregnant, because that way she has that folic acid on board. Calcium is going to be another really important supplement. This is really important for fetal bone and teeth development and strengthening. And of course, it's also important for maternal health during the pregnancy as well. And of course, you can get calcium with dairy products. Broccoli and kale have a lot of calcium, and same with certain fortified cereals. Vitamin D is very important. This is needed to build fetal bones and teeth. And you can get vitamin D. Most people take it just as a supplement. You can just take it as a pill, but you can also get vitamin D in fatty fish like salmon, and it's also in fortified milks and orange juice as well. Iron is going to be important. This helps the mother to create more blood and oxygen carrying capacity for the fetal oxygenation. So good iron intake is important. And remember, you can get iron in meats. You can get iron in foods like raisins. There's a lot of places you can get iron. DHA is an omega-3 fatty acid, and that's really important for eye and brain development of the fetus. Typically, that's going to be included in a prenatal supplement, but you can also get DHA in oily fish. So again, two servings of oily fish per week is actually a good thing. And then there's also iodine. Iodine is really vital for fetal brain and nerve growth. And this can be found in most foods nowadays. Most salt nowadays is iodized, so rarely is it an issue. But if you're someone who does not eat iodized salt, I'd recommend you increase intake of certain animal proteins like chicken and fish, and you can also get this in sea veggies like seaweed as well. So those are all very important. But just like there are foods we recommend, there are also going to be those foods that we say, okay, you really, really want to avoid these in pregnancy. So again, fish high in mercury. Mercury really affects the development of the nervous system. It affects the kidneys and the lungs. So absolutely, you got to avoid those fish high in mercury. There's also cold deli meats like lox and hot dogs. The reason you want to avoid those is those can carry listeria, which is a bacteria that can affect many foods. And listeria in someone who's not pregnant really doesn't cause many issues. But remember, when someone's pregnant, their immune system goes down. So listeria can be deadly to a pregnant woman. That's also why pregnant women should avoid raw meats and eggs. And that's also why they should avoid those unwashed produce. We don't want them to get bacteria that their body can't fight off. Pate and liver should also be avoided. That's actually high in vitamin A, and at high levels, this can cause congenital defects and also cardiac and central nervous system issues as well. So got to avoid foods high in vitamin A. Caffeine, you want to limit caffeine use. Typically, you don't want to take in more than 200 milligrams per day. Why is that? Well, more than that can lead to placental and umbilical cord vasoconstriction, and that can actually decrease fetal oxygenation. So a maximum of about a 12-ounce cup of coffee per day, that's okay. And of course, alcohol is a no-no. Alcohol at high doses is known to cause fetal alcohol syndrome, and that can cause multiple issues. It can cause facial deformities, growth issues of the bone and joints, vision and hearing problems, and very commonly it causes learning disabilities as well. There are also many, many drugs to avoid in pregnancy as well, and I'll go through these briefly. NSAIDs, those non-steroidal anti-inflammatory drugs, ibuprofen, Advil, Motrin. You got to be careful with these because these can significantly increase the risk of miscarriage. They can also cause increased fetal and maternal hemorrhage at the time of birth. So especially near the end of pregnancy, these are a no-no. Just so you guys know, aspirin at low doses sometimes is used in pregnancy for certain conditions, but as a rule, no one should be taking large doses of aspirin. ACE inhibitors and ARBs, these are two blood pressure medications that you do not use in pregnancy. These cause oligohydramnios, which causes the amniotic fluid to go down. They can cause fetal growth restriction and fetal abnormalities. So what should you use instead? Beta blockers, calcium channel blockers, those are going to be the agents we use. Sulfonamides and fluoroquinolone antibiotics, stuff like ciprofloxacin, levofloxacin, Bactrim, can't use those in pregnancy. Why is that? Well, those fluoroquinolones can cause significant problems with the fetal muscle and skeletal growth and can increase the risk of miscarriage. Sulfonamides also increase the risk of miscarriage and can cause other issues. So instead, typically we use penicillins. Chloramphenicol, that's a big one. What is chloramphenicol? Well, that's actually something that treats a variety of infections like bacterial meningitis. That medication specifically can cause something called gray baby syndrome, which is a life-threatening condition that causes circulatory collapse in the newborn. These babies are basically born with this ashen gray appearance. They have abdominal distension, and they can die from that easily. So we do not use that in pregnancy. Codeine is another one. Narcotics in general, you got to be really careful about in pregnancy, but especially codeine is one we do not use in pregnancy because it's known to cause heart defects, and it can also cause spina bifida. Instead, we want to usually use a non-narcotic option like Tylenol is a safe option. Also goes by acetaminophen, of course. Warfarin, we also want to avoid that. That's known to cause birth defects, and it can cause bleeding behind the placenta, which can, of course, reduce fetal growth, and it can also cause placental abruption. Benzodiazepines, clonazepam, lorazepam, etc. If taken too close to delivery, they can cause life-threatening withdrawal symptoms in the newborn. We avoid those. Isoretinoin, that's also known as Accutane. This is a medication that's used to treat really severe cystic acne, and you never use it if someone's pregnant because it's known to cause really, really severe birth defects. In fact, women who take this medication need to be on 2 forms of birth control, and they get monthly pregnancy tests because the effects to the fetus are so bad. It causes face, eye, ear, skull, central nervous system, heart, thymus, all kinds of problems. And these kids tend to grow up to have lower IQs, so we do not use it. Bismuth subsalicate or Pepto-Bismol, also don't use that. That increases the risk of bleeding problems. Castor oil, well, this causes no direct harm to the fetus. This increases the risk of maternal diarrhea and dehydration, which can increase the risk of preterm labor. Mineral oil, too. This doesn't cause direct harm to the fetus, but mineral oil can affect the ability of your body to absorb nutrients. And the reason a lot of women take mineral oil is they get constipated and they want it to help the constipation. Do not use mineral oil for constipation in pregnancy. Instead, something like Colace would be a much better option, or docusate sodium. Cigarettes, of course, that increases a lot of health risks, increases the health risk for cleft lip, cleft palate. It increases the risk of bleeding with pregnancy. It causes lower fetal birth weight. And it's really not healthy for the pregnancy. Believe it or not, this was a long time ago, but maybe like 60 years ago, believe it or not, cigarettes used to be advertised by healthcare professionals as a way to have an easy pregnancy or an easy birth. You don't want to push too hard during birth? Smoke those cigarettes and you'll have a lower birth weight pregnancy. Well, yes, that would make the delivery easier, but it's not good for the fetus, so we don't recommend that. Marijuana also, newer research is showing that causes low birth weight as well and some abnormal neurological development in the fetus. Typically, we see that babies born to mothers who take marijuana have lower IQ levels. And then illicit drugs, of course, cocaine, heroin, crack, methamphetamine, fentanyl. These are all really bad. They can cause withdrawal to the newborn baby if the mother took them too close to delivery. They certainly increase the risk of miscarriage, of preterm birth, of stillbirth. So all drugs should be avoided at all costs, of course. Okay, we're going to take a quick second. I just want you guys to see these QR codes here. If any of you guys are not already with Archer and you're interested in it, if you find this lecture helpful and would like to have access to more lectures like it, I definitely recommend the SurePass combo. That's definitely our #1 recommended package. It really provides everything you need to do well on that NCLEX. So if you're an RN, you'll want to use this QR code. And if you're an LPN, you'll want to use this one here. So definitely feel free to use those if you're interested. Okay, next we're going to talk about antepartum testing. And just so you guys know, we are going to take a break in just a little bit. About midway through the presentation, we'll take a break, and it'll be a good long one, about 15 minutes. So don't worry, you will get a break. Okay, so when we're looking at antepartum testing, there's a couple tests that really take a lot of explanation. The blood type and RH factor, the glucose challenge test, and the non-stress test. Those come up a lot on the NCLEX, so I'm going to talk about those in future slides. But let's quick talk about the other ones. There's STI testing. That's definitely done on all women who are pregnant because, excuse me, I got a runny nose, because if a woman is a carrier of an STI, we want to treat it before that can be passed on to the newborn, because a newborn does not have a strong immune system, and STIs can actually kill newborns. Even something as simple as chlamydia or gonorrhea, it can kill a newborn. Urinalysis, that's done for all women at the start of pregnancy, but definitely you can repeat that anytime during pregnancy to test for any number of things. It tests for glucose if you're worried about diabetes. It tests for protein in the urine. That would be something we'd see with preeclampsia. It tests for ketones. It tests for a variety of things, including infection as well. So we use urinalysis a lot. Ultrasounds are done throughout pregnancy. All women get an ultrasound around 20 weeks. That's called the anatomy ultrasound. And it's about an hour-long scan where they measure a variety of things, extremities, organs, and they basically make sure the baby is healthy. There are also first trimester ultrasounds that are done in very early pregnancy, typically between 6 to 10 weeks, where they'll date the pregnancy and figure out how far along they are. There are growth ultrasounds that are usually done in later pregnancy if we're worried that a baby is growing too fast or too slow. And there are third trimester ultrasounds as well if we're worried about a baby's well-being. So we use ultrasound a heck of a lot in pregnancy. There's also Group B strep. Group B strep is actually a little Q-tip swab that we do within the vaginal canal around 36 weeks pregnant. And the reason we do that is a fair number of women, about 25% of women on average, are going to be carriers for Group B strep. It's not harmful to the woman, but it can be harmful to the newborn if the mother passes that on to the baby. So we test for it right before they're due to give birth. And if they test positive for Group B strep, we give the mother an antibiotic during labor, and that prevents transmission to the fetus. Finally, there are kick counts. And kick counts are basically something you teach the mother to do on her own. Now, kick counts, like non-stress tests, are only accurate in the third trimester. So starting in the third trimester, what I tell my patients is every single night, I want you to sit back in your favorite chair and relax. And for the next hour, I want you to count every single movement your fetus makes. If within that hour you have 10 movements, your baby's fine, they're healthy. If within an hour you do not have 10 individual movements, you need to call the office because something might be wrong with your baby. All right, so let's dive into blood type and RH factor. What is this? Well, of course, we need to know the blood type of the mother in case she needs blood, right? Is she A, B, O? What is she? But in pregnancy, something that's even more important is that RH factor. Is she RH positive or is she RH negative? Well, most adults, most people are going to be RH positive. 90% of people are RH positive. And if the mother's RH positive, we don't need to worry because RH positive blood can be exposed to both RH positive and negative blood and nothing bad will happen. But about 10% of our pregnant patients are going to be RH negative. Those are the ones you have to watch like a hawk because if they have a baby who's RH positive, that's a setup for something called erythroblastosis fetalis. So what is that erythroblastosis fetalis? Well, if you have the mother here who's RH negative and her baby is RH positive, what happens if that baby's blood crosses the placental barrier? Well, the mother's blood will not like that, and she'll produce anti-RH antibodies. These are attack cells. These cells over time will attack the newborn's, or I'm sorry, the fetus's blood, and it will kill the child. So we want to prevent that at all costs. And something you guys should know about those anti-RH antibodies is once a mother makes those, she has them for the rest of her life. She cannot get rid of them. So our job is to make sure she never develops those. How do we do that? Well, first of all, we've got to do testing at the right time. Indirect Coombs testing is what we do during pregnancy. It's indirect because we can't directly test the baby yet because the baby's in the womb. We can't poke in there and test the baby's blood. So indirect Coombs testing is done on the mother's blood sample. It's done at the beginning of pregnancy, and it's also done at 28 weeks. And basically, we test the mother's blood. If her blood is RH negative, a reflex test will be done to see has she made those anti-RH antibodies. If she has made those anti-RH antibodies, I'm sending her to a high-risk clinic. She's not seeing me anymore. But most of the time, women won't have those yet. Direct Coombs testing is performed on the newborn's blood sample when they're finally born. What we do is we test that baby's blood. If the baby is RH negative, we don't worry. Both mom and baby are RH negative. It's fine. If the baby's blood is RH positive, again, a reflex test will be done to see has that baby been exposed to those anti-RH antibodies. So that really dictates how we manage those patients. And what we do to prevent those antibodies from forming is we're going to give the mother a medication called RhoGAM. RhoGAM is a medication that basically stops your blood from making those anti-RH antibodies that attack RH positive blood cells. What is RhoGAM? Well, RhoGAM is actually a sterilized solution made from human blood that contains a tiny small amount of RH positive proteins. And basically those proteins give your immune system a little taste of it, and it prevents you from making those anti-RH antibodies. When do we give RhoGAM? Well, the number one time we always give RhoGAM is at 28 weeks. If you are a mother and you're RH negative, you will get RhoGAM, because RhoGAM, if given at 28 weeks, and it's just a shot in the arm, is going to work for the next 12 weeks at preventing erythroblastosis vitalis. So 28 weeks plus 12, that takes you till your 40-week due date. So it protects you during the end of pregnancy when the risk is highest. There's two other times we might give RhoGAM. In early pregnancy, before 28 weeks, if the mother has any vaginal bleeding, she's going to get a shot of RhoGAM, because if she's bleeding vaginally, we don't know if she was exposed to fetal blood. So we give RhoGAM to make sure she doesn't produce any of those antibodies. Finally, after the baby is born, if the baby is RH positive, the mother gets that third dose of RhoGAM. So remember, RhoGAM prevents the mother from making those anti-RH antibodies. Very, very important. All right, now let's talk a little bit about the glucose challenge test. Again, this is something that all pregnant women have to do. And basically, it's always done around 28 weeks. The 1 hour test is not fasting. You just come in like you normally would. And basically at the start of the visit, you're given a drink that has 50 grams of glucose in it. Kind of tastes like a flat soda. Not too tasty, but it works well. And basically, I always tell my patients, glug that down as fast as you can, and we're going to have you wait an hour. And after that hour, we're going to draw your blood and check your blood glucose level. If your blood glucose level is 140 or higher, you might have gestational diabetes. That means you have to do the 3 hour test. But if your blood glucose level is 139 or lower, you don't have gestational diabetes. You're okay. Well, man, I really feel bad for those moms who have to come in for the 3 hour glucose test, because they got to come in on another day. And this test is fasting. You have to fast 8 hours prior to the test. And first thing we do when you come in is we do a fasting sugar. After that's drawn, we give the mother 100 grams of oral glucose, a big old flat soda drink. And we check her blood again at 1, 2, and 3 hours, and we check her blood glucose level. Now, do you guys need to know the levels at 1, 2, and 3 hours? No, that's not really likely to show up on your test. What you need to know is if the mother passes her 3 hour test, she does not have gestational diabetes. But if she fails her 3 hour test, that's when she gets the diagnosis of gestational diabetes. And typically I send her to a diabetes specialist to work on that. And we'll talk more about gestational diabetes a little later. Now let's talk about the non-stress test. So remember, the non-stress test is really only considered accurate starting in the 3rd trimester, 28 weeks or beyond. If you do the non-stress test before then, not very accurate, not worth doing. Why would we do this test? Well, this test really assesses the fetal well-being and oxygenation of the placenta. How's that baby doing? Are they healthy or aren't they? And basically what it does is it evaluates the changes in the fetal heart rate with movement. Well, what do we mean by movement? Do we mean the mom's like dancing around? Not that kind of movement. What we refer to when we say movement are the uterine contractions. And believe it or not, the mother's uterus contracts the entire time she's pregnant. She just can't feel it until she's in labor typically, but she's still contracting. That uterus is always contracting. And every time that uterus contracts, it puts stress on the fetus. It compresses the placenta, it compresses the fetus, and it puts stress on them. Well, what do we want to happen to the body when the body's under stress? The heart rate should go up. Just like me, if I went sprinting up a flight of stairs, I sure hope my heart rate goes up, otherwise I might pass out. So if there's an increase in fetal heart rate with a contraction, that's an acceleration. That's a good thing. That's a healthy baby. If there's a decrease in the heart rate with fetal movement, that's a deceleration, and that's usually bad. What that tells us is when there's stress on that fetus, they're not tolerating it. And that means they probably wouldn't tolerate labor either, because during labor, the contractions are even stronger and more frequent. So what are the results? Well, the results are either going to be reactive or non-reactive. So in order for it to be reactive, you need at least 2 accelerations in a 20-minute period. But it can't just be a quick little acceleration. It needs to be an acceleration that goes above the baseline by at least 15 beats per minute. And each acceleration needs to last for at least 15 seconds. If you get 2 of those, that's good. That's reactive. Non-reactive is not good. If there are not at least 2 accelerations in 20 minutes, that means we need to do further testing. And I'll talk about that in a minute. So this is a nice little memory trick. Remember, the non-stress test is non-reactive when it's not good. Remember the 3 N's. And real quick, this is, similar to what a non-stress test would look like. Typically on the bottom here, you would probably see more contractions than what I'm seeing right here. But you can see on the top, there are some pretty good accelerations here. This is a good acceleration. This is a good acceleration. Looks like we have a little acceleration here. So within 20 minutes, there are 3 accelerations. This would be considered a reactive non-stress test. And this is what a woman looks like when she's hooked up to the monitor. She has 2 probes. The bottom one is measuring the contractions, and typically the upper probe is monitoring the fetal heart rate. So what do you do if you have a non-reactive non-stress test? Well, we don't know how that fetus is doing. We're not reassured because it wasn't reactive. We need to do further testing. And what we're going to do is a contraction stress test. This is what we do when the non-stress test is non-reactive. Basically, for this test, we send the mother to the hospital. She always has to do this in the hospital because oxytocin is going to be administered to induce contractions. And remember, oxytocin is an oxytonic. It increases the intensity and speed of contractions. So basically, it kind of simulates labor. And basically, what we want to see is if we increase contractions, what's that going to do to the baby? Are they going to tolerate it, or are they going to show signs of stress? So the results are negative when they're normal, because what we're looking for is we're looking for decelerations. Does the baby have decelerations with a contraction stress test? So if they don't have decelerations, it's negative. That's good. It means that the baby tolerated the contractions. If they get a positive contraction stress test, not good. That's bad. That means the baby had decelerations. That tells us that the baby was in distress. Probably we shouldn't deliver this baby vaginally. We might want to consider a different mode of delivery. All right, let's try another question, mix things up a little bit. So this question says, which of the following are required for a non-stress test to be considered reactive? Select all that apply. So there might be more than one answer. So go ahead, just like we did with the last question, put your answers in the question area and just give it your best shot. Do I expect all of you to get this right? No, just give it your best shot and we'll talk through it. Good job, Anna. I'm seeing a lot of good answers here. Okay, let's go ahead and look at those answers. Very good job. Most of you either got really, really close or you got it entirely. So the right answers are going to be A and C. Remember, for a non-stress test to be reactive, you need at least 2 accelerations. They need to go above the baseline by at least 15 beats per minute, and they need to last for at least 15 seconds. So A and C are our answers. A lot of you guys also chose E, and I can see why you chose that. But remember, with a non-stress test, we're not worried about fetal variability. We worry about fetal variability when we do fetal heart rate monitoring. And remember, fetal heart rate monitoring is done over a longer period of time, and we're going to talk about that next. With a non-stress test, all we look for are there accelerations or aren't they? All right. So I told you we do fetal heart rate monitoring next, and that's exactly what we're going to do. So fetal heart rate monitoring, there's some terminology you want to know first. First of all, just like we just mentioned, variability. Variability stands for the fluctuation in the fetal heart rate. As I sit here, my heart rate isn't a steady rate. It's changing constantly. If I'm gesticulating and moving around a lot, my heart rate's going to go up. If I'm just sitting here, it's going to go down. Same with the fetus. The fetus shouldn't have a stable line. It shouldn't have a flat line for a heart rate. That's bad. There should be some movement, some fluctuation. Remember, an acceleration is speeding up of the heart rate. That's a good thing. Deceleration, slowing down of the heart rate, typically not good. Sometimes it's okay though. Reassuring means, yeah, that baby looks healthy. I think they're going to do okay. And then non-reassuring really means something's wrong here with the baby. We need to investigate further. So remember, variability. What we want is moderate variability. We want moderate movement in the heart rate. We don't want absent. We don't want a flat line. That means there might be something wrong with that fetus. Nor do we really want marked. We don't want so much movement that that baby's heart rate is all over the place. We want it just right in the middle. This would be an example of absent variability. With absent variability, the heart rate moves around by no more than 5 beats per minute. It's mostly just a flat line. Not good. This isn't good. Market variability can be bad, but it can also be okay. If you see this and it's only for a short span of time, it's probably okay. You know, if the baby just happens to be moving around a lot, there's going to be market variability. But if this is a prolonged strip that shows jagged ups and downs with that fetal heart rate, it's moving around by more than 25 beats per minute, that can indicate that fetus is in some distress. This is what we want to see. We want to see that moderate variability. The heart rate, it's moving around. There's some fluctuation, but not too much, not too little. Just right in the middle is what we want, just like Goldilocks and the Three Bears. Accelerations, remember, are always a good thing. This is showing us that when there's uterine contraction, the fetus responds to that stress in a healthy way. The heart rate goes up. Every time there's a contraction, this is a healthy baby, is what I'm seeing. If there are consistent accelerations, that's a good thing. Decelerations typically are bad, except for early decelerations. Early decelerations tend to indicate that the head is being compressed. And remember that, when the baby's being delivered, for instance, there's going to be frequent contractions and compression of that fetal head and neck. That's expected. And what happens when the uterus compresses the head and neck is it triggers the vagal nerve. The vagus nerve, when it's stimulated, lowers the heart rate. So this is actually a normal finding. Early decelerations, we don't worry too much about. Well, how do you tell if it's an early deceleration? Well, early decelerations are going to match with the contraction. So you can see this contraction, when it starts, is where the deceleration starts. When the contraction ends is when the deceleration ends. Early decelerations mirror the contractions. They start and stop at the same time. And they tend to make a U shape. They're usually fairly uniform in shape, and they make a little U. Variable decelerations, not good. These mean that the cord is being compressed, there's pressure on the cord, and therefore the umbilical vein and artery, which means that no oxygen can get through to the fetus during that time, which causes that sudden deceleration in the heart rate. And so with these, one thing I'll note is variable decelerations don't always match with the contraction. They can, but very often variable decelerations happen randomly as well, especially if you have something like an umbilical cord prolapse where the cord is being, extending out through the vagina and being compressed by the fetal head. That would happen more randomly. It wouldn't matter when the contractions are happening. But one of the main features of a variable deceleration is it doesn't make that nice U, it makes a V usually. There's going to be a sharp decline in heart rate and a sharp incline. That's a variable deceleration. And remember, these are bad. These are not good. The fetus is in distress if this is going on. And if we don't figure out what's going on here, the fetus isn't getting oxygen, they could have acidosis and they could die. So we need to figure this out fast. Late decelerations, also not good. Late decelerations really tell us that there's placental insufficiency. There's decreased blood flow to the placenta. And this often happens with maternal hypotension, for instance. If the mother's blood pressure drops really, really low, not enough blood will get to the placenta and you'll get placental insufficiency. The number one time I see that is when someone gets an epidural and the epidural gets turned up a little too high. Suddenly you can have severe maternal hypotension. So what do? You correct that as soon as possible. You try to treat the underlying issue. Some other causes might be severe maternal dehydration or severe anemia of the mother as well. How do you diagnose these? Well, like early decelerations, they're going to make that nice U. But the difference is they happen in a delayed fashion after the contraction happens. So there's a contraction, delay, deceleration. Contraction, delay, deceleration. That is the pattern. So you can see this contraction happens, and after the midway point of the contraction, that's when the deceleration starts. Contraction happens after the midpoint, deceleration. Contraction, delay, deceleration. So it makes a nice U, but it's delayed. So this is just something I hand drew. I will admit it doesn't look pretty, but it gives us the information you need. So in red, remember this bottom strip is always the contractions. That's in red. That's the mother's uterus contracting. In blue, these are early decelerations. Remember, they make a nice U and they match up with the contractions. Late contractions, there's a delay, then the U. Delay, whoops, click the slide, then the U. Delay, then the deceleration. And then remember, variable decelerations can happen randomly. Doesn't necessarily match up with the contractions, but there's a sudden decline in heart rate. Makes more of a V or a deep U. So that's kind of how you tell the difference. And to remember these, you want to remember veal chop. Anytime you have fetal heart rate monitoring on your little cheat sheet, I recommend you write this down just to remind yourself. Veal lines up with chop. So V, variable, lines up with C, cord compression. E, early decelerations, stand for H, head compression. Those are okay. A, accelerations are always okay. We like to see those. And then L, late decelerations, mean placental insufficiency. Those aren't so good either. So what would we define as reassuring and what would we define as non-reassuring? Well, definitely reassuring would be a baseline heart rate in the normal range between 110 and 160. Moderate variability, that's a good thing, and accelerations are a good thing. Non-reassuring is one of 5 things typically. There's fetal tachycardia, and I'm not talking about a whoop, it went up really fast. No, it's sustained fetal tachycardia over 160. Fetal bradycardia, not just a quick blip down, it's a sustained bradycardia. Decreased variability, variable decelerations and late decelerations. These are the big signs of non-reassuring. What do we do when we have a non-reassuring fetal heart rate? We do lion pit. Lion pit is the mnemonic that tells us what to do when the fetal heart rate is non-reassuring. So first of all, if there is Pitocin or oxytocin running and the fetus is in distress, number one thing you do always is you discontinue that Pitocin, because remember, what does Pitocin or oxytocin do to the uterus? It increases the contractions, it increases the frequency and intensity, and that puts stress on the fetus. So number one thing we do, we stop the stressor, we stop the oxytonic. Then we start with L, we lay the mother on her left side. What does that do? Well, if we lay the mother on her left side, that's going to take the weight of her big belly, her big uterus that's compressing her blood return, and it's going to push that off to the side so the inferior vena cava is not compressed, and that will allow more blood to go to the heart and be oxygenated, and therefore more blood and oxygen goes to the fetus. We want to increase IV fluids for the same reason. If we increase the blood volume, we increase how much blood and oxygen will get to the fetus. That's also why we give the mother oxygen. We put on high flow oxygen because if we oxygenate the mother's blood, that oxygen will go to the fetus. And then very last thing we do, we notify that healthcare provider. But first we do all of those other things. Phew. All right. Why don't we go ahead and take a break here and we'll pick up in about, why don't we say 10 minutes? So go ahead and take a little break. Up here, I do have a link to one-on-one tutoring. There's a bunch of wonderful tutors within Archer. So if any of you guys are really struggling with any concepts, especially if you're struggling with maternity, for instance, and need a one-on-one, any of these wonderful tutors can help you. So feel free to use the link here. But I'm going to go ahead. I'm going to turn off my camera just for about 10 minutes. Go ahead, go take a nice little break, use the restroom, all that good stuff, and we'll meet back at 17 after the hour. So I'll see you guys soon. All right. All right, we'll get started again in about a minute. So go ahead, get settled, and we'll get started again and keep making our way through maternity. At the end of the presentation, if we have time, I also have some next gen questions based on maternity that we'll practice together, again, if we have time. So we'll see how far we get. Okay, it is officially, the 10 minutes are up. So let's go ahead and keep on moving through the content. So next, what I want to go through is GT-PAL. This is another type of question that can show up on the NCLEX. And basically, GT-PAL is, a set of letters that basically tell us what their obstetrical history is at a glance. So it's a really nice communication tool if we're trying to know at a basic level, what has their obstetrical history been? So first of all, there's the G. G stands for gravidity. This is the total number of pregnancies this patient has had, including their current pregnancy. But the tricky thing here is twins only count once. Remember, even though there's two fetuses, it's still just one pregnancy. So each pregnancy is counted individually. So for example, if you have a patient who is currently pregnant and they've had one prior delivery, they would have a G of 2. Next, we have term. Our T stands for term. This is the total number of pregnancies that were carried to term. And remember, what is term? Term is 37 weeks or beyond. Full term is 40 weeks. But remember, at 37 weeks, that's when all the organs are fully developed. So we really want them to make it to 37 weeks if possible. And remember, twins only count once here. Two babies, one pregnancy. Next, we have preterm. Preterm are the number of pregnancies that ended between 20 weeks and just before 37 weeks. So if the pregnancy ended between 20 weeks and or just before 37 weeks, that would be considered preterm. So the tricky thing here, though, is a lot of times, they'll make this a little tricky. They'll say, oh, if someone had a preterm delivery at 18 weeks, would we count that as preterm? No, even though they're calling it preterm, preterm is really only between 20 weeks and 36 weeks plus 6 days. It ends between them. Abortions, A stands for abortion, are the number of pregnancies that ended prior to 20 weeks. So if it ended at 19 weeks and 6 days or before, it's considered an abortion. And this is where certainly terminations are counted, but also spontaneous miscarriages are counted as well. So again, if the pregnancy ended before 20 weeks, it's going to get an A. And then finally, L stands for living children. This is the number of children who are currently alive, and this is where we count twins or triplets. So if you have two twins that both survived the delivery, you would have an L of 2. So let's do a little GT-PAL practice. Let's work on this together. So let's try this one. A 41-year-old patient who presents in her second trimester. She has a history of a healthy delivery at 38 weeks and an emergency C-section at 29 weeks. First of all, what would we get for the G? How many times has this patient been pregnant? So she's presenting in her second trimester. She has a healthy delivery at 38 weeks, and she has a history of a C-section at 29 weeks. How many G's would we give her? Good. Exactly. She would get a G of 3. Perfect. How about T's? How many of her pregnancies made it to term? What would we give for the T? Harmon, good job. Anna, yep. Good. Laris? Close. No, that would be the G. Nisha, good. All right, for T's, we would get a T of 1 because we had one that made it to 38 weeks. How many preterm deliveries happened? How many pregnancies ended between 20 weeks and just before 37 weeks? Exactly. Exactly. That would also be one. There's just the one at 29 weeks. Do we have anything for A? Any numbers that we give for A? Good. A would be 0 because no pregnancies ended before 20 weeks. They all ended after 20 weeks, so there wouldn't be any A's. Finally, how many living children are there? How many living children? Good. I would assume 2 would be the answer. They didn't really tell us the outcomes of these deliveries, but I would assume both children survived. So the 38-weeker was a living child, and I guess I would assume the 29-weeker was also a living child. Do we count the current pregnancy as a living child? Nope. Nope, that you don't count a child as living until they've actually been born. So you just get 2 for living. Good. Let's try one more and then we'll keep moving. So this one says a 41, sorry. No, this one is the one I wanted to do. A 22-year-old patient presents for her first prenatal appointment. She is estimated to be 8 weeks pregnant. Her OB history includes a twin pregnancy that was aborted at 12 weeks and a singleton pregnancy ending in a C-section at 32 weeks where the infant did not survive. So what do we get for G first of all? She's coming in for her first appointment. She had a history of a twin pregnancy and she had a history of a singleton pregnancy. What do we do for G here? Good. She's going to get a G of 3. Exactly, G of 3. She is currently pregnant. She has a history of the twin pregnancy, and she had the pregnancy that ended at a C-section at 32 weeks. So G of 3. Okay, how many of her pregnancies made it to term? How many made it to term? What would the T be? Yes, the T would be 0. It would be 0 because no pregnancies made it to 37 weeks or beyond. They all ended before 37 weeks. So it would be a 0. Okay, how many preterm deliveries did we have? What's the P? What number do we give the P? How many pregnancies ended between 20 weeks and just before 37 weeks? Good job, Ugo. Maria, yep. Good. A P of 1. We have one pregnancy here that did not survive. The infant did not survive, but they were delivered via C-section at 32 weeks. So it was a preterm delivery. It ended preterm. How many abortions? How many A's do we give this patient? What number do we give A? Good job. I wondered if this one might be a little tricky, but you guys are doing great with it. Yes, we would get an A of 1. We have one pregnancy that ended at 12 weeks because it was aborted. A lot of times people say the A is 2, but it's not. Remember, twins only count once within a pregnancy. So there's an A of 1. And finally, how many living children are there? What do we do for L? Yep. Exactly. L is 0, unfortunately. She's currently pregnant. We don't count that. We can't count the abortion at 12 weeks. Those twins didn't survive. And we can't count the 32-weeker because that infant didn't survive either. So unfortunately, this is an L of 0. So just keep practicing those. Those can be very, very tricky, but the more you practice them, the easier it will get. Okay, real quick, a lot of times during these presentations, we also get questions about the small group tutoring. In addition to one-on-one tutoring, we have small group sessions where we teach a specific topic, and those are really nice because they're much less expensive than a one-on-one. They're only $25 for an hour, and you'll have up to 15 students within that class per one tutor. And there are a variety of wonderful topics. There are test plan areas, prioritization, SATA, NCLEX, or I'm sorry, NextGen, dose calc, EKGs. Anytime you guys are struggling on a specific topic, always check out and see if those small group sessions are being held, because that's a pretty inexpensive way to get some really good tutoring. So feel free to scan that QR code if you're interested in those at all. Okay, so let's keep it moving. So next I want to go over the common complaints of pregnancy. Kind of talked a little bit about these, but there are some things that just really commonly happen in pregnancy. And I always tell people, being pregnant isn't for sissies. It's hard. It's sometimes very uncomfortable. So we'll talk about those. So first of all, skin changes and rashes, pretty common when you're pregnant. One of the first changes that can happen is melasma. That's also known as the mask of pregnancy. Basically, women, when they're pregnant, they can get this really dark pigmentation across their forehead and cheeks because of the hormonal changes. The good news is that it does usually fade quite a bit after the pregnancy. And the number one thing you can do to prevent this, wear lots of sunscreen, because sun exposure makes this worse. Dark spots, darkening of freckles and moles, that's usually going to happen when you're pregnant. And very often you're going to end up with quite a few more moles and freckles than you had when you started the pregnancy. Skin changes are common. Pregnancy glow. Well, why is that? Well, basically in pregnancy, there's a significantly increased volume of blood. Your blood volume increases by 50% when you're pregnant, and that increases the circulation to the face, and it looks brighter. You get this glow. So that's a positive change. But a lot of times women will also get acne. Because of hormonal changes, there's increased oil production. So acne is pretty common. The good news is, though, that women can use oil control face washes. The one product they really want to avoid, though, is retin-containing products like retin A. Why is that? High levels of vitamin A. And if you recall back from our nutrition discussion, We don't want pregnant women getting too much vitamin A. There's also the linea nigra. What is this? Well, that's that dark line that extends from the top of the abdomen all the way till the bottom, and it kind of divides the abdomen in half. Most women do get this, and again, oftentimes it will fade after pregnancy, but not always. Some women get that permanently. Many women are going to get stretch marks. Most women do. About 90% of pregnant women develop these. And unfortunately, there is a genetic component to stretch marks. So some women are going to get much more than others. You can, minimize these to a certain extent by having good hydration and by gaining weight nice and slow. You don't want to gain big chunks of weight at a time. Otherwise, you're going to get a lot of stretch marks, of course. PUP stands for pruritic urticarial papules and plaques of pregnancy. And PUP really is a rare, relatively condition that can occur in pregnancy. It occurs in about 1 out of 150 pregnancies, but as someone who works in women's health, I used to see it all the time. And basically, this causes these itchy, red, raised patches to show up on the skin, usually inside the stretch marks around the abdomen. And the good news is this goes away almost immediately after you deliver. It's typically caused by the hormones of pregnancy again. And then finally, a lot of times pregnant women get a lot of skin tags as well. There's also increased vascularization. Like I just said, blood volume increases by 50% during pregnancy. So what can that cause? Well, bloody noses are going to be a lot more common in pregnancy. So I always tell my patients experiencing those, maybe try sleeping with a humidifier. If they're getting really bad, you can take a little Q-tip and put some Vaseline on the end and just kind of rub that on the inside of your nose as well. Swollen, tender gums. I always tell my pregnant patients, use a soft bristle toothbrush and consider using a water pick instead of floss because your gums are going to bleed very easily. Spider veins, spider nevi. These are the small reddish vessels that kind of branch outward, and you can see these usually on the cheeks, face, and upper chest area and arms. This is more common in Caucasian women. We see it very common in that population. And many women, again, appear to have a genetic predisposition towards these, but for most women, these fade after delivery. Very commonly, women get varicose veins. Those are those bulky bluish veins that typically occur on the legs during pregnancy. Again, family history plays a really big role here. One of the best things you can do to avoid those is when you're pregnant, avoid standing or sitting with crossed legs for long periods of time. These patients want to elevate their feet frequently. They want to get up and walk around occasionally. And they also want to avoid excessive weight gain because that can worsen these as well. In severe cases, sometimes we can order compression stockings to help reduce these. And believe it or not, you can actually get varicose veins of the vulva, the outer vaginal area, and those are horribly uncomfortable. So sometimes we'll use a vulvar support belt for those patients that kind of holds pressure against the varicose veins. And you're absolutely right, Nisha. Someone just said, hey, varicose veins are a risk for clotting, for PE. That's true. We didn't know that for a long time. We used to think, oh, varicose veins, they just kind of look bad. No, they actually can slightly increase the risk for blood clots. So I definitely like these patients to get their varicose veins checked out by a specialist too. And then finally, these women tend to get a lot of edema. Again, they have a lot of extra fluid in their body, and that tends to cause edema, especially in the lower extremities, the ankles and feet and that sort of thing. That comes with the territory. Morning sickness is also very common. Because of those hormonal changes, there's often going to be nausea and sometimes vomiting secondary to pregnancy. Typically that occurs before about 9 weeks, and for most people it goes away by 20 weeks. but not for those patients with hyperemesis gravidarum. We'll talk about them in a little bit. Most women have this in the first trimester, and luckily most women start to feel better again pretty quickly after that first trimester. Rarely it becomes hyperemesis gravidarum, but the good news is for most women, lifestyle modification typically treats this effectively. You can eat smaller, more frequent meals. You can try eating bland foods, sitting upright for an hour after eating. Those will all help. But actually, vitamins and supplements can be very effective in treating this as well. In particular, vitamin B6, when it's dosed 3 times a day, very, very effective at reducing nausea. Taking a little extra vitamin C tends to help as well. And then, you know, some supplements or herbals that can help. Ginger is very effective at reducing nausea. So there's a variety of things we can try to help this before we ever even consider medications. So we didn't specifically talk about this, but I want you guys to try this question, and we'll talk about it in a little bit more detail after you try it. So this question says, an 11-week client is complaining to the nurse about her hemorrhoids. The nurse understands that hemorrhoids occur because of pressure on the rectal veins from the bulk of the growing fetus. All of the following are measures to alleviate hemorrhoid pain except one. What's that one thing they should not do if they're experiencing hemorrhoid pain? Go ahead and put that answer in the question box when you're ready. I mentioned this briefly, but a lot of the other things I didn't specifically talk about, but we'll go over it. A lot of you are getting this right. Good. Okay. A lot of you guys did really, really well on this one. The answer for this one is going to be A. We do not want this client to take mineral oil to soften her stools. Remember, mineral oil decreases absorption of essential nutrients. Exactly. Unfortunately, a lot of women use mineral oil because they're like, oh, it'll help me go to the bathroom. There are better ways to go to the bathroom. Mineral oil is not the best way to do it. And remember, a lot of women get constipation because the hormones cause peristalsis to slow down. And as they get constipation, when they have to go to the bathroom, they might strain, and that can cause a hemorrhoid. What are some good ways to treat hemorrhoids? Resting in a side-lying position helps take pressure off of that. Increasing the client's fiber and water intake is good. Cold compress to the area is perfectly safe and soothing, and a warm compress to the area is also very helpful. Okay, next I want to talk about mood changes. Very commonly in pregnancy, women will experience mood swings and irritability, and actually for some women, this is an early symptom of pregnancy. However, mood changes can be quite a bit more concerning if there's already an underlying condition like anxiety or depression or bipolar disorder, because what we've seen through research is these get worse as the pregnancy continues. In fact, this has been measured. When someone starts their pregnancy with depression and they don't treat it, every trimester it tends to get worse because of the hormonal changes. Therefore, it is so important, if you have a patient with depression or a mood disorder, make sure it's well managed before they become pregnant. Now, a lot of people say, I'm afraid, I don't want to take mood medications. I'm afraid it's going to hurt my baby. Well, SSRIs, SNRIs, those are really safe overall. The benefits far outweigh the risk of taking those. So absolutely, being on the right medication is essential. Again, many women, they find out they're pregnant and they're stable on a medication and they panic. They go, oh no, I shouldn't be on this. And they suddenly stop it. and then their mood gets significantly worse throughout the pregnancy, and it becomes very hard to treat. So again, managing mood disorders early is very important. And also after the pregnancy, very good point, Nisha. Postpartum depression and anxiety are very important to manage as well. Finally, or I'm sorry, also there's common aches and pains. Like I said, being pregnant isn't for sissies. It's hard stuff. First of all, headaches usually get quite a bit worse and more frequent in pregnancy due to hormonal changes. Rarely chronic migraine sufferers will actually feel better. Most women feel worse though. If women are having increased headaches, usually the first thing I recommend is increase your protein and water intake. But if that doesn't work, actually magnesium supplements, just taking a little extra magnesium calms down that irritation in the brain, and Tylenol or acetaminophen is also a very safe option. Back pain, super common in pregnancy. It's rare I don't hear about this from someone because the center of gravity as the pregnancy progresses shifts forward, and that of course worsens as the pregnancy progresses. So it's really important to teach your patients to stretch frequently, and actually pregnancy yoga is especially helpful for managing back pain. You can also do pregnancy support belts. Those are very effective as well. Joint pain is very common because of the release of hormones relaxin and progesterone. Those increase the laxity of those ligaments and make them pull and hurt more frequently. So again, frequent stretching is a good thing, but you don't want to overstretch either, knowing that that relaxin is being released. Mild heat can be applied to the joints. You can use heating pads as long as it's a mild heat and not on the abdomen. And actually you can take warm baths, but not hot baths. If the bath is so hot that it's leaving that red ring on your skin, it's too hot. You want a mildly warm bath. And then also symphysis pubis dysfunction, or SPD, also known as pelvic girdle pain, is the worst. This is when pelvic joints become stiff and actually move unevenly. And this can occur in the front where the joints actually kind of grind against each other in the bottom or in the lower back. This causes severe pain and dysfunction. And these patients, if they roll over in bed, if they shift their weight, if they walk, anything can set off severe pain. So an early referral to physical therapy is very important for these patients. Sometimes these patients need assistive devices like wheelchairs and crutches if they're really having trouble with mobility. And sometimes stronger pain meds are needed for these patients as well. This is the last one. The final one is increased risk for infection. And I mentioned this before. This is really significant during cold and flu season. That's why we should absolutely be recommending our flu and COVID vaccines. These women, when they get sick, they get really sick and they can have really high fevers that really are damaging to fetal development. In fact, you know, I know there's a lot of hubbub out there about vaccines and worrying, oh my gosh, is this vaccine going to cause autism? There's been no evidence of that. What we have seen, though, is when mothers are pregnant and they get really high fevers, that can affect the IQ and cognitive development of the fetus. So we want to vaccinate and treat early to prevent that from happening. These women are going to get more frequent vaginal and urinary infections. And again, this is because of hormonal shifts. Some infections are harmless, like yeast infections are really common in pregnancy. Those don't really cause any harm, they just cause itching. But bacterial vaginosis, dangerous in pregnancy. That can increase the rate of miscarriages in pregnancy, and actually urinary tract infections increase the risk of miscarriage and preterm labor. So we're aggressive when we treat that. Women who are pregnant should absolutely avoid kitty litter. Kitty litter can contain toxoplasmosis, which is a parasitic infection that's shed in the cat feces, and you can also get it from undercooked or contaminated meat. So you can be around cats, but someone else in the house has the job of cleaning the litter. And then, of course, these women need to be careful of foodborne illnesses. They want to be careful to wash their hands well, thoroughly cook their meals, and make sure they're really washing their produce well. Now we're going to move into those high-risk pregnancy conditions, and these are the things that are going to show up a lot on the NCLEX. Like I mentioned, hyperemesis gravidarum is really extreme morning sickness. This is when morning sickness becomes severely intense and it just does not stop. It causes severe vomiting. So if you compare the two, on the left here we have morning sickness, and over here on the right we have hyperemesis gravidarum. With morning sickness, they have nausea, but it only sometimes causes vomiting. With hyperemesis, there's constant nausea and vomiting, and it's excessive and persistent. I've had patients who are so severely nauseated that if they even swallow their own saliva, they're immediately vomiting. These women are extremely sick. With morning sickness, the nausea, again, it usually goes away by 20 weeks. You just got to hang in there. But with hyperemesis gravidarum, doesn't stop. It continues the whole pregnancy. In morning sickness, the vomiting doesn't cause dehydration because they're able to keep down some food and water, but with hyperemesis, typically they can't keep anything down. So over time, they become dehydrated, they lose weight, and that can cause electrolyte imbalances. So these women can become very, very sick. Well, when should we be concerned? Well, if I have someone who calls me and says, hey, I haven't ate or drank anything all day, I can't keep anything down, you're coming in, I'm evaluating you. And the very first thing I do is I check a weight. Are they losing weight? If they're losing weight, they're probably dehydrated. And I'm going to do an exam. I'm going to check skin turgor. Remember, for skin turgor, you can check by tenting the skin on the back of the hand. If it pops right back down like mine, I have good hydration. But if I were to let go and it stays tented, that's a sign of dehydration. Mucous membranes, I have them go, ah, and if they're dry as a bone, I'm thinking they're dehydrated. And finally, I check their heart rate, because if their heart rate is sky high, very often it means they're quite dehydrated. And remember, this can affect electrolytes. As they become more and more dehydrated, they can develop hypernatremia because the sodium that's left behind becomes more concentrated. As they're vomiting excessively, they can have hypokalemia and hypochloremia, which can make them very, very sick. So how do you manage these patients? Well, you try the dietary and lifestyle changes first. Sit up after meals, eat bland meals, avoid liquids with your foods, kind of separate them so you don't get too full. Try all those things. Usually that's not quite enough for hyperemesis. So very often we also need to start them on an antiemetic, a medication for nausea. One of my first choices is usually promethazine. I also sometimes use compazine and Reglan as well. Something we used to use all the time was ondansetron or Zofran, but unfortunately newer studies show that can increase the risk of cleft lip and palate, so we don't use it very much anymore. Sometimes these women end up needing IV fluids. In fact, in a lot of my patients, what I would do is I would set them up with an outpatient infusion clinic. And basically 3 or 4 times a week, they'd go to that infusion clinic and they'd get 1 to 2 liters of fluids. And man, would that help them feel better. And actually, sometimes these women become so sick they can't tolerate anything in the GI tract, even via a tube feeding. So some women end up hospitalized on TPN as well. These women can get very sick. Next, let's talk about preeclampsia. What is preeclampsia? Well, this is a condition that typically starts after 20 weeks gestation. Why is that important? Well, if you suspect that a patient's blood pressure is rising and it's before 20 weeks gestation, it's probably not from preeclampsia. It's probably that patient's underlying chronic high blood pressure. But if you have a patient whose blood pressure is rising after 20 weeks, we know that the placenta is big enough at that point and it's releasing enough hormones that that's the point where it's probably being caused by the pregnancy. And it can't just be one high blood pressure. It needs to be two high blood pressures of 140/90 or higher. But it can't just be the high blood pressures. There also needs to be protein in the urine. These patients, when you do a urinalysis and you do that dipstick, you'll see high proteins in it. And the reason for that is preeclampsia. That the combination of protein in the urine and high blood pressure, not a good combination. You got to watch those patients closely, because if preeclampsia gets severe enough, especially if those blood pressures get high enough to cause severe brain irritation, people have eclampsia. They end up getting seizures, and seizures in pregnancy can be deadly to both the mother and the fetus. So our job is to make sure that preeclampsia never becomes eclampsia. What are some risk factors for preeclampsia? Well, if you have multiple fetuses, you might have more than one placenta, or you might have one big placenta. Remember, when the placenta grows, when there's more placental mass, risk for preeclampsia goes up. Chronic hypertension, if you start out with hypertension or you develop hypertension during the pregnancy, you're at higher risk for preeclampsia. Obesity is a big risk. Increasing age, and remember, advanced maternal age is age 35 or above. And I know that doesn't seem very old, and a lot of people are like, that's not advanced age, and it's not old, but that's when the risks in pregnancy start to increase. Once women become 35 or higher, their risk goes up for a lot of things. African American descent, much higher risk of preeclampsia, so we got to watch those patients closely. A family history of preeclampsia, if you had a mom or a sister with it, you're more likely to get it. Prior preeclampsia in a previous pregnancy increases the risk. Diabetes or gestational diabetes increases the risk. In vitro fertilization, autoimmune disorders, and kidney diseases all significantly increase the risk of preeclampsia. What are the signs and symptoms? Well, the main things: increased blood pressure, protein in the urine, and weight gain or swelling are the main features. Why do people have so much swelling with preeclampsia? Well, when you lose protein in your body, you don't have enough protein in your blood volume, in your vasculature. And if you have low protein in your blood, fluids don't like to stay in the vasculature. They do third spacing. They move out into the extremities and you get swelling. So you don't want to lose this protein because that causes a lot of fluid gain and edema. And that's why women with preeclampsia, they don't just get swelling of the lower extremities. They get swelling everywhere. They get puffy round faces, especially around the eyes. Their hands get really tight and puffy. So definitely, these patients get really sick. And the classic triad spells out the mnemonic PRE: proteinuria, rising blood pressure, edema. Those are the three features with preeclampsia. How do you manage these patients? Well, depending on how severe it is, you might deliver them, and we'll talk about that more on the next slide. If you deliver preterm, if it's before 37 weeks, you need to prepare to deliver a preterm baby. What do you do if you expect a baby to be delivered before 37 weeks? You give the mother betamethasone, which is a steroid injection she gets in the arm. And ideally, she should get 2 doses of betamethasone. Why do we give that? Well, if we give betamethasone before that baby is delivered preterm, it rapidly helps to develop the baby's lungs so they have less breathing issues when they're born. Depending on the severity of the preeclampsia, especially if we think they're at high risk for seizures, we'll also give them magnesium sulfate. Remember, magnesium is the electrolyte that's calming in the body. So if we think that high blood pressure is causing irritation and inflammation, we give them magnesium that calms that down and it reduces seizure risks. And we don't just give a one-time dose of magnesium. We typically give it as an IV drip over the course of 24 hours. And by the way, people do not like being on magnesium. It makes you feel really crummy, dizzy and headachy. You feel really tired, but it's really important. And of course, we're going to treat the blood pressure with antihypertensives. But first, let's talk about when do we deliver? Well, if it's preeclampsia without severe features, meaning there's just elevated blood pressure, it's not crazy high, there's no signs of pre-seizure activity, there's no weird headaches or blurry vision, that patient's a pretty normal risk. That patient we can deliver at 37 weeks or beyond. But if we have preeclampsia and those blood pressures are getting crazy high, the blood pressure is 160 over 110 or higher, we're not messing around. We're going to deliver them as early as 34 weeks because we don't want the baby in that environment. We also don't want them having seizures. If they have eclampsia, if they have full-blown seizures, typically we try to wait till 34 weeks, but hey, if the mother's not tolerating it, we do it beforehand. And if they're having HELP syndrome, we deliver them ASAP. And we'll talk about HELP syndrome in just a minute. What antihypertensives are used in pregnancy? Well, remember, beta blockers like labetalol, calcium channel blockers like nifedipine, these are our first line choices. This is what we use first. And typically those are effective at treating the blood pressure. If one of those or both of those are not effective, we'll also add hydralazine. Hydralazine is a direct vasodilator that works by relaxing the blood vessels, and it's very effective at treating blood pressure. So we can also use that as a second line therapy. The medications, if you recall, that we never use for blood pressure in pregnancy, ACE inhibitors and ARBs. No, we do not use that in pregnancy because it can cause oligohydramnios, amniotic fluid decreases, which is not good for the baby. It can cause fetal growth restriction and more. It's not good. So let's do a little question based on that. A pregnant woman with pre-existing hypertension is being seen in the clinic. Her blood pressure continues to rise despite attempting first-line therapy with antihypertensives. Which of the following medications will be used for the prenatal patient resistant to other blood pressure lowering medications? So what do we use if the first line agents don't work? And again, go ahead and just put that answer right in that question area. And there's only one right answer. I'm sorry. This question, this is the select all that apply. I'm sorry, I was misreading it. So what medications are considered safe to use? All right, so really A, B, C, and D are all of our safe medications that you can use in pregnancy. A, the calcium channel blocker, and C, labetalol are first line agents. Hydralazine is going to be our second line agent. And actually methyl dopa is a third line agent that we do not use very often. But furosemide we probably would not use during pregnancy. We typically don't want to give furosemide during pregnancy. So those are our answers. So like I said, HELLP syndrome is really a very, very severe condition, and it's something that a lot of people have not heard of before. HELLP syndrome stands for hemolysis, elevated liver enzymes, and low platelet count. And basically, this is a life-threatening pregnancy complication that's considered to be a variant of preeclampsia. Both occur in late pregnancy or can occur immediately after childbirth. Well, while there's no known cause for this, we do know that people who have preeclampsia and eclampsia are at a much higher risk for this condition. And truly, it is a medical emergency. It needs immediate treatment as it's life-threatening. 25% of women who get this will not live. It's deadly. So what are the symptoms? Similar to severe preeclampsia. You can get epigastric pain because it causes your liver enzymes to rise, so liver becomes inflamed. You get nausea and vomiting. You can get severe headaches like you do in preeclampsia. You can get blurry vision, severe swelling. So very often this gets mistaken for preeclampsia, but it's much, much more severe. How do we treat this? Well, we treat with corticosteroids. That actually reduces the dropping platelet count. It helps to correct that. We use definitely antihypertensives, and actually sometimes we end up administering blood products and components because if their platelets drop too fast or their red blood cells go through hemolysis and they lose too many, we need to replace that. But ultimately, rapidly delivering these patients is the best treatment, and getting the baby out of that harmful environment is very, very important. Here's another little QR code for any of you who are interested. We also have this nice little next-gen boot camp for repeat test takers. So for any of you guys who are really, struggling to pass, you've taken it a couple times and you're just like, what do I do now? Well, this is really designed to help you get the tools you need, especially to succeed with those next-gen questions. So the next time we're hosting that is July 24th. And definitely, if you're interested in that, look at that QR code. It's definitely a great program. Really helps those people who need good structure and a really nice schedule to help guide them through the review process. Okay, next let's talk a little bit about gestational diabetes. What is gestational diabetes? Well, gestational diabetes is just diabetes of pregnancy. It doesn't mean you're going to have diabetes when you're not pregnant, but it does mean that you have diabetes during the pregnancy. And why is it that some people get diabetes when they're pregnant? Well, when you're pregnant, oftentimes the pancreas just isn't able to deal with those increased insulin requirements. And this happens because insulin becomes more resistant in pregnancy, secondary to hormones. And actually, the way we metabolize carbohydrates in pregnancy is a little different. So these combined can increase the risk of diabetes. Now, if someone has gestational diabetes, again, it does not mean they'll have normal diabetes, but it does increase their lifetime risk for diabetes. What are some risk factors? Well, definitely similar to people who are at risk for diabetes, being overweight or obese, having a sedentary lifestyle, having a history of pre-diabetes. Those are all important risks, definitely. Prior history of gestational diabetes in a previous pregnancy. Actually, having polycystic ovarian syndrome increases the risk of diabetes in general, but also in pregnancy. About 10% of women have PCOS, and this is a condition that causes hormonal imbalances, and it also causes insulin resistance as well. A family history of diabetes. Definitely if there's a prior history of a baby weighing over 9 pounds, that's a big risk. I've had patients before who say, yeah, I've never had gestational diabetes. And then the next thing they tell me is, yeah, I had an 11-pound baby. In my head, I'm thinking, yeah, you probably had gestational diabetes. You just weren't accurately diagnosed. And then again, being African American, Hispanic, American Indian, or Asian American all will increase the risk as well. Assessment-wise, remember, we always screen for gestational diabetes somewhere between 24 and 28 weeks. Usually at 28 weeks is the standard of care. And we can also screen for glucose in the urine. Why do we get so worked up about this? Well, it leads to complications. One of the biggest complications I just mentioned is macrosomia, a big old baby. If you have a baby greater than 8 pounds, 13 ounces, it's too big, it's macrosomic. And sometimes these babies need to be delivered earlier to make sure they fit through the vaginal canal. And certainly they cause more trauma when they're being delivered, and more harm can come to the baby. My husband, actually, when he was born, he was just shy of 12 pounds. He was a big baby, and he broke both of his clavicles, both of his collarbones when he was born. So it's definitely not ideal. You also, when you're diabetic, have increased risk for high blood pressure. So when you have gestational diabetes, your risk for preeclampsia goes up. And then finally, babies born to mothers with uncontrolled gestational diabetes very often have serious hypoglycemia after they're born. Why is that? Well, when the baby's in the womb, it's surrounded by all this sugar, this uncontrolled diabetes. So the sugar is really high. And during the pregnancy, the fetal pancreas actually does make its own insulin. So it's surrounded by sugar, and the pancreas is just chugging along, producing tons of insulin to accommodate that. But as soon as the baby's born, it's no longer surrounded by that glucose, but it takes a while for the pancreas to realize that. So for those first couple days after delivery, the pancreas is making lots of insulin, and that blood sugar drops like a box of rocks. It just drops really fast. So you absolutely have to watch these kiddos really close. For the first 48 hours, you do frequent blood sugar checks. But how do you manage this in the mother? Well, absolutely. As soon as someone's diagnosed with gestational diabetes, you teach them how to monitor their blood sugars, and you teach them how to control their diet and exercise. Definitely with diet, you tell them increase protein, increase fiber and whole grains, eliminate those simple carbs, and you want to aim for about 30 minutes of moderate activity per day. If that doesn't work, though, typically we teach women how to give themselves insulin. Insulin is the safest medication to treat gestational diabetes. A lot of people ask me at this point, couldn't you do metformin or glipizide or something like that, an oral agent? Well, we used to do that, and it's not considered safe anymore because research showed that babies born to mothers who took those seriously dangerously low blood sugars after delivery. So now we just use insulin. But the good news is, as soon as that baby is born, the mother can stop her insulin. Next, I want to talk about cholestasis of pregnancy. What is this? Well, this is actually a maternal liver condition that typically occurs in later pregnancy, and it basically over time causes bile acids to enter the bloodstream. And as bile acids rise, fetal safety is significantly compromised. What happens is, basically we think the pregnancy hormones are involved. And as the pregnancy hormones increase, that seems to slow down the normal excretion of bile through the bile duct. And as that bile becomes backed up and trapped in the bile duct in the liver, it enters the bloodstream and becomes very, very dangerous. When bile acids enter the bloodstream for the mother, it causes maddening, horrible itching. We're talking about the worst itching you've ever felt in your life, especially itching on the palms of the hands and soles of the feet. If you remember back from before, I talked about PUPS. That's a more common condition that's very benign. The itching with PUPS starts in the abdomen around those stretch marks. Cholestasis, palms of the hands, soles of the feet. That's when you got to worry. What are the risk factors? Well, if someone has a history of cholestasis in a prior pregnancy, much more likely they're going to get it again. Actually, about 60 to 70% of women do have a reoccurrence. And actually, if the symptoms were severe, more likely you're going to have a reoccurrence. If there's a history of liver damage or disease, that increases the risk. And definitely being a parent of multiples, twins, triplets, increases the hormones, increases the risk. So what are the complications? Well, remember, for the mother, severe itching. Often there can be scarring as a result from maternal scratching. I've had patients who scratch themselves in their sleep and they wake up with these horrible scars on their body. It's awful itching. Rarely this can cause a disruption in the way the mother absorbs fat, which can be a problem. And this can result in lower vitamin K dependent factors, which can also affect the mother's ability to clot. So it can slightly increase bleeding risk as well. For the fetus, the risks are even greater. It can increase the risk of preterm birth. It can increase the risk of lung problems, but mostly it really, really increases the risk of stillbirth. So we got to watch this really, really carefully. How do we treat this? Well, unfortunately, there's no known prevention. So the focus is always early recognition and intervention. If the patient is still in the third trimester and it's prior to 36 weeks, the focus is on monitoring the fetus to make sure they're okay. Typically, we do really, really frequent non-stress tests to make sure the baby's okay. And we also give a medication called ursodiol, which actually helps to lower the bile acids in the blood. And this sometimes helps relieve the itching as well. If it's after 36 weeks, we deliver no matter what because the risk of stillbirth is just way, way too high. What can you do about the itching? Well, itching can be improved slightly by soaking the affected skin. You can try anti-itch creams. Certainly we use Benadryl and stuff like that, but really the main treatment is to give the ursodiol, and certainly after delivery, these symptoms resolve very quickly as well. All right, next let's move to ectopic pregnancy. This is our final high-risk condition, and then we're going to try some next-gen questions. All right, so what is an ectopic pregnancy? Well, ectopic means out of place. So this is when an egg is fertilized, but it's implanted outside of the uterine cavity. Remember, the uterus is a remarkable organ. It can go from the size of a fist to the size of a watermelon and back again within 6 weeks. It's incredible. But not many other organs, really no other organs can do that. So if the pregnancy accidentally gets stuck in the fallopian tube, most of the time that's what happens. It can also implant in the cervix or abdominal cavity. That's not good. It's very, very dangerous because especially if that ectopic pregnancy is in the fallopian tube, guess how big a fallopian tube is? About as big of a noodle of spaghetti. It's not big at all. So pretty early on, that pregnancy as it grows is going to cause that fallopian tube to potentially rupture, which is incredibly dangerous. So how are these patients going to present? Well, classic signs are, we think they're pregnant. Maybe they had a missed period or they have a positive pregnancy test. And then in addition to that, they will often have vaginal spotting and really bad, severe abdominal pain. Typically, though, the abdominal pain is not in the middle. It tends to be on one side or the other. It's unilateral abdominal pain because typically it's one of the fallopian tubes that are being affected. Over time, these patients lose appetite and eventually they'll start having severe nausea and vomiting. And if this puppy is about to rupture, these patients can have severe dizziness and they can even have syncopal episodes. I can still remember vividly when I was a newer nurse in the ER, I had a patient with a suspected ectopic. She was pregnant, she was spotting, she had unilateral pain, she was feeling woozy. So me and another nurse were placing large bore IVs in case she needed fluids and blood. 1 minute she's talking to me, the next passed out, white as a sheet. It had ruptured. This happens fast. So our job, of course, is to prevent the rupture from happening. So if you suspect this, if you have someone who's pregnant, they have unilateral pain and spotting, get an ultrasound ASAP. You need to detect it with the ultrasound. And if it looks like it's about to rupture, they're going to surgically remove it. And basically what they do is they cut out the portion of the ectopic or the fallopian tube that contains the ectopic, and they get rid of it. And so that destroys the functionality of that fallopian tube. So if that woman wants to get pregnant in the future, it's going to be a bit harder for her. So ideally, we want to prevent this from even getting close to rupture. We want to catch it when we can still give the medication methotrexate. Methotrexate is a medication that basically stops the embryo from growing, and eventually it will cause the fetus to be, or I'm sorry, the embryo to be aborted. A lot of people at this point say, wait a second, can't you do something to save that embryo? No, unfortunately, there's nothing we can do as of right now with the technology we have. If an embryo implants and it's implanted outside of the uterus, it will not survive no matter what. So our focus has to be on saving the mom, preventing a rupture, preventing hemorrhage, and sustaining life. Remember though, remember if a mother is Rh negative, even if it's an ectopic, she's going to be bleeding. And if that embryo is Rh positive, she could develop anti-Rh antibodies and develop erythroblastosis fetalis with her next pregnancy. So if you have someone who's Rh negative and they're bleeding because of a suspected ectopic, give RhoGAM. Better safe than sorry. Don't let their body make those anti-Rh antibodies. And that is it for the main content. So thank you so much for hanging in there. If any of you are still struggling with maternity, let me know. You know, I certainly do one-on-one tutoring, and we can definitely talk about that. There is a second half. There's also a lecture on L&D. We're not going to do that today. That's going to be a future Wednesday webinar. But if you're a member of Archer, you can watch that on demand. So if you're already part of Archer, you can watch that L&D lecture on demand and see the next half of Women's Health, which is good. Our next Wednesday webinar is going to be on congenital heart defects with Morgan, who's a wonderful presenter. I don't know about you guys, but I really struggled with studying those congenital heart defects when I was a student. I was always just, I can't remember those. So definitely, if you struggle with those, you know, click on that QR code, scan it, and register, because Morgan's going to do a great job. And that's going to be on the 19th, 6 to 7 p.m. Central Time, so at a slightly different time. So, like I said, if we had some extra time, I wanted to make sure we had a little time to go over some practice questions together. But before we do that, does anyone have any specific questions for me that they just were dying to ask, that they want to ask really quick before we move on? Hopefully you've been able, you've been able to get your questions answered throughout, of course, but anything you wanted to ask me? And that's okay. If you already had your questions answered, that's perfect. Okay. Well, let's go ahead and do some next gen practice. For those of you who want to do some next gen practice, that's next on the docket. So we'll do some next gen specifically tailored, of course, to maternity. So someone just asked, can you talk about placenta previa? Well, that's actually going to be part of the labor and delivery lecture. So absolutely, that's important content. It does very commonly show up on the test, but that's really kind of part of a separate lecture. So my recommendation is, you know, to watch that on demand to get that content, because there's a ton of stuff to go through with labor and delivery. And really today we're covering maternity. That's a good question I can answer quick. Someone just asked, can an HIV positive mother breastfeed her baby? Yes, if she is on antiviral therapy. And actually, that's something that's very important. If you recall, when I was talking about those routine tests in pregnancy, I mentioned that STI testing is part of what we do. We always screen for HIV. And if someone's positive, ASAP, we put them on antivirals, because that significantly reduces the chance of exposure and transmission to the fetus. Same with breastfeeding. As long as they're on antivirals, they can breastfeed. Okay. If you have any quick questions, I can answer those. If it's an entire concept that you missed, like non-stress test, if we have time after the next gen questions, I will go back, but I want to make sure I keep moving forward, just because, you know, we've already covered that content. So certainly if I have time at the end, I will go through that. But let's maybe dive into let's dive into the next gen questions. Okay. All right, let's go ahead and start those. So these are going to be single questions to start. So this first question says, the nurse is reviewing the medical record of a client who is pregnant at 35 gestational weeks. Click to highlight the findings in the medical record that require follow-up. Oh, you're welcome, Harmon. I'm glad you enjoyed it. So for this, we want to highlight anything that's abnormal. So what would we highlight that's abnormal? You're welcome, Maria. What do you guys think? And again, just put the answers right in that question box if you have an idea. Yeah, I agree, Carla. Good. Good job, Anna. I agree. Yep. Harmon, Laura, yep. Ugo, good. Good job, guys. So good. A lot of you guys got the right answers. So first of all, this non-stress, yes, good. This non-stress test is non-reactive. And remember, a non-reactive non-stress test is not good. Non-reactive, not good. So we want to highlight that. On the other hand, a contraction stress test is bad when it's positive. Exactly, Manpreet. Very good. A positive contraction stress test tells us, man, when we added that oxytocin, that baby's heart rate decelerated in response to those contractions. So this baby isn't doing well. That's not good. The fetal heart rate was totally normal. We wouldn't highlight that. But yeah, this fasting glucose is too high. It's out of range. So we would definitely highlight that too. Excellent. Good job. Let's try a slightly different question next. Let's try this one. So this question says, the emergency department nurse is caring for a female with right lower quadrant pain. Nurse's note, 28-year-old female presents with unilateral right lower quadrant pain, pelvic pain, and vaginal bleeding that she describes as spotting that started 2 days ago and has increased intensity. She reports that she took a home pregnancy test 3 weeks ago and it was positive. She reports her pain is an 8 out of 10. She describes her pain as stabbing and constant. Other symptoms she reports includes frequent urination, breast tenderness, and nausea. The client takes no medications, has no medical or surgical history, and she reports a medication allergy to penicillin. So you guys should start coming up with a hypothesis. Basically, the way I analyze these type of questions, when there's a nurse's note, what I like to go through is I like to go through and figure out what's abnormal. Well, the pelvic pain, right lower quadrant pelvic pain, vaginal bleeding. She's pregnant. That's important to note. The pain is severe. It's constant and stabbing. Those are the things we want to focus in on. And what I want to do is I want to take those abnormal findings and I want to start to come up with a hypothesis in my brain. What do I think is going on here? So start coming up with that hypothesis. What do you suspect is going on with this patient? Okay, let's look at the vital signs. I agree, Laura. Yep. So oral temperature looks good. That's 98 degrees Fahrenheit. Pulse is 86 beats per minute. Regular respirations are 16. Blood pressure is 113/68. And O2 saturation is 96% on room air. Pretty decent. Yeah. So what 3 findings, remember I just said, okay, these are the things I want to focus on. What 3 findings in the nurse's note require further investigation? So it's telling you there are 3 answers. So you want to pick 3 answers. And you want to pick the abnormals. If it's expected, we don't want to pick that. We want to pick the things that are unexpected. What do you guys think? Yep, Jemmy. That's a big one. Carla, I agree. Yep. Getting a variety of answers, which is always a good thing, I think, because then it, you have a lot to learn from the question. A lot of you guys are getting it right too, though. Way to go, Veronica. Okay, let's go ahead and see what it says. A, B, and C. Good job if you got those right. So the things that were abnormals, well, the fact that she's pregnant is concerning because of the symptoms she's having. Pelvic pain is concerning. We do not expect pelvic pain in pregnancy. Vaginal bleeding, we do not expect that in pregnancy. So these are our main symptoms we want to look at. Breast tenderness, that's expected during pregnancy, so we're not worried about that. Frequent urination, expected during pregnancy. Same with nausea. So if it's expected, we don't worry about that. We worry about the unexpecteds. And for those of you who were thinking that this was probably an ectopic pregnancy, you were absolutely right. Remember, the main symptoms of ectopic are the patient is pregnant, or we suspect they're pregnant, they have unilateral pelvic pain, and they have bleeding or spotting of some sort. So very good job if you came up with that hypothesis. That was a good one. All right, let's try another one. This says the client presents for a routine antepartum visit. After reviewing the primary healthcare provider's progress note and the nursing assessment, which antepartum testing would the primary healthcare provider likely prescribe? So let's see what this says. So the primary healthcare provider's progress note. We have a 40-year-old nulliparous female at 25 gestational weeks. The client is receiving appropriate antepartum care, taking a prenatal vitamin, and is appropriately vaccinated. She has a pre-pregnancy medical history of vitamin D deficiency, metabolic syndrome, and hypothyroidism. She's, again, this is the details. She's 5'7". She's got a weight of 194, so her BMI is 30. Looks like her fetal heart rate is about 130, and her vital signs, it looks like temp is 97, pulse 85, respiration 16, blood pressure 119/73, and the O2 saturation is looking okay at 96. So the client will need what as evidenced by what? So what test is this patient going to need based on what issue? So based on what you know, she's 40, she looks like she's got an elevated BMI. What test do you think we might want to do on her? This is a trickier one, I think. Jimmy, good job. That was tricky. I would say that a lot of you are getting this right, but I'm getting a variety of answers. You're right, Jemmy. That's exactly the reasoning. Good. Ruth, you got it. Good. All right, most of you have answered. So the right answer is we will need a glucose tolerance test because the BMI is too high and this patient has advanced maternal age. And if you recall, a risk factor for gestational diabetes, advancing age, and an elevated BMI. So this patient has a couple risk factors for gestational diabetes. So we're going to need that glucose tolerance test. And even though she's only 25 weeks, I might do that a little early. If you guys recall, typically we do the glucose tolerance test around 28 weeks for most patients. But if the provider, someone like me, says, I'm seeing some risk factors here. She's overweight, she's advanced maternal age, I might choose to go ahead and do that a little early to screen early and treat it early if I suspect that's going on. So good job for those of you who got it right. That was a tricky one. All right. Okay, let's try another one. Just a couple more. All right, the nurse cares for a client who is pregnant at 35 gestational weeks at the outpatient clinic. Click to highlight the clinical findings in the nurse's note that require follow-up. So we'll go through this together. We'll start with this and then we'll move to the client assessment. So 1300, the client reports reporting, I don't know why that's their choice. So the client reports swelling in her hands, feet, and face. She reports a frontal headache that started 1 day ago. The client also reports frequent urination. She says she has been experiencing 12 fetal movements per hour. So what out of this portion of the question would you guys highlight? And remember, it's the abnormals you're going to highlight. What's not okay here? That's what I'm thinking too, Anna. I agree with you. Good thinking. What about this though? What would you highlight in here that tells you that's what's probably going on? You're mostly right, Laura. Mostly, yeah. Yes, Ugo, I agree. Anna, yes, that's big. Mm-hmm. Alaris, you got it. Okay, definitely. So what I would highlight personally is I would highlight the client reporting swellings of the hands, feet, or face. That's unexpected. We don't expect that with a normal pregnancy. And we also do not expect that frontal headache. Not expected with a normal pregnancy. Is frequent urination a normal finding with pregnancy? Is that a normal symptom, frequent urination? Yeah, that's considered normal. So we wouldn't highlight that because it's expected. What about 12 fetal movements per hour? Remember what I said about those fetal kick counts. Is 12 movements an hour good or is it not good? Is it normal or abnormal or normal? It's an active baby. That's good. Yeah, if you have at least 10 movements per hour, you got a good, healthy baby. So what you want to highlight here is the swelling in her hands, feet, and face, and the frontal headache. That's what's abnormal. So let's go ahead and look at the client assessment next. The blood pressure is 153/85. Heart rate is 89 beats per minute. Temperature 98.8. We've got +2 pitting edema in the ankles. Urine dipstick reveals +3 proteinuria, and there's a frontal headache. What are we gonna highlight there? Yes, Nisha, that's not good. I agree with that. What else would we highlight? So Nisha said that urine dipstick. I agree. We don't like seeing all that protein in the urine. Yep, Jemmy, you're right. That's what I'm thinking. Yep, Veronica, I agree. Anna, yes. Blood pressure, that's a big one. You also mentioned the edema. That's not expected normally. The frontal headache, good job. Someone just got that too. Remember, a frontal headache, not expected with a normal pregnancy. Really, everything should be highlighted here except for the temperature. So when we do this question, we should have an answer like this. So we want to highlight all of the unexpected abnormals. Swelling of her hands, feet, and face, frontal headache, blood pressure, edema, +3 proteinuria, and that frontal headache again. Frontal headaches and blurry vision with preeclampsia, if you recall, that's actually a symptom of severe preeclampsia. Severe preeclampsia can lead to eclampsia and seizures, so we don't like hearing that at all. All right, very good job. A lot of you guys caught on to the fact that this was probably a preeclampsia patient. Okay, and that is officially it for our questions. So like I said, if we had time at the end, I promised I would go back and quick review non-stress tests. So I'll do that quick and then I'll let you guys leave after that. All right. So if you guys already heard the talk on non-stress test and you don't want to hear it again, that is perfectly okay. I'm just going to repeat this quick for those who maybe joined late and missed it. So a non-stress test, again, is a test that we use, and we only do this in the 3rd trimester. Remember, it's only accurate in the 3rd trimester. We do this test to assess how healthy is that fetus. Are they getting enough oxygen? And basically what it's evaluating is the changes in the fetal heart rate with movement. When we say movement, what we mean are uterine contractions. When there's a uterine contraction, which puts stress on that fetus, does the heart rate go up? That's a good thing. That's an acceleration. It means when there's stress, the heart rate's able to accommodate that. Or if there's a contraction, if the heart rate goes down, that's not good. That's a deceleration, and it really tells us, I don't think that baby's going to tolerate labor very well. But results are only reactive when there's at least 2 accelerations within a 20-minute period. But they can't just be one little quick acceleration or 2 quick accelerations. They need to meet some standards. They need to be above the baseline by at least 15 beats per minute, and each acceleration needs to last for at least 15 seconds. If you get 2 of those, that's reactive. That's a good thing. A reactive non-stress test, really actually research has shown a reactive non-stress test tells us that fetus is probably going to be safe and healthy for the next 2 to 3 days. It's really reassuring. If there's a non-reactive non-stress test, though, you don't at least get 2 accelerations, then that's non-reactive. That's not good. And that really tells us maybe there's something problematic going on with that baby. And what we would do to further test for this, if they have a non-reactive non-stress test, is we would do a contraction stress test. And remember the 3 N's. A non-stress test is non-reactive when it's not good. So remember those 3 N's. And again, this is what a non-stress test would look like. Typically, you would see contractions down here, but you can see there are some nice accelerations. There's a good acceleration here. There's another good one here. So this would be a reactive strip. Oh, that's a very good question. Someone just asked me, when would we do a non-stress test? When would we do that? Well, I would do a non-stress test if I'm worried about how the baby is doing health-wise. If I maybe have a patient call and they say, yeah, my baby hasn't been moving very much lately. Yeah, I haven't felt movements at all today. And they're in the 3rd trimester. That baby's big enough in the 3rd trimester, they should be feeling a lot of movements. So if they're telling me, no, I'm not feeling any movement, I'm going to do a non-stress test to make sure, is that baby doing okay? So if we're worried about fetal well-being, if we think, oh, something maybe that baby is in distress, a non-stress test will tell us how they're doing. All right, someone else real quick asked me if I could cover HELP, and I can definitely do that real quick as well. Let me fast forward to HELP here. Nope. I'll get there. There we go. Okay, HELP syndrome. So HELP syndrome stands for hemolysis. Hemolysis, remember, is when red blood cells are destroyed, and break apart and are no longer effective at carrying oxygen. Elevated liver enzymes, so those liver enzymes rise, which means the liver gets inflamed and the platelets will drop really, really rapidly. And if you recall, HELP syndrome is, it's considered to be a variant of preeclampsia. What we see HELP syndrome usually in patients who have preeclampsia or eclampsia, or who have a higher risk for that. Those people are going to have a higher risk for this condition. And remember, this is a medical emergency. It needs quick treatment. It's life-threatening. 25% of women diagnosed with this will die. It's super, super serious. So why is it so life-threatening? Well, remember, red blood cells are hemolyzing, liver enzymes are rising, the liver is inflaming, and the platelets are dropping rapidly. So this patient could bleed out if they have a bleed somewhere. So there's a lot of different things going on that really affect their health. How do we treat this? Well, we use corticosteroids. Steroids are going to stop the platelets from dropping. We use antihypertensives because definitely people with HELLP syndrome have severely high blood pressures typically. And certainly if their red blood cell count is really low or their platelets are dangerously low, we might give blood products, pack red blood cells or platelets. And eventually we're going to deliver. We're usually going to deliver really as quickly as possible because these patients, you know, again, the baby and the mother are at severe risk for death if we do not deliver them rapidly and treat this carefully. All right. Someone else had a quick good question. Someone just said, hey, if the patient has an incompetent cervix, why don't they have a non-stress test or a contraction stress test? Well, typically an incompetent cervix is when the cervix, remember that the end of the uterus, let me change my slides to explain this better. Bear with me. I'm gonna go back to a slide here. If I can find it. Here we go. So remember, the cervix is the opening to the uterus. Some women have something called an incompetent cervix, where their cervix, instead of being nice and tightly closed, you know, what happens is it opens up and dilates way too early. And I've had patients with incompetent cervixes who start dilating at 16, 17 weeks, and that can actually cause them to deliver way too early and they can have a stillbirth or miscarriage. So when someone has an incompetent cervix, actually the best way to manage that is with something called a cerclage. A cerclage is this really thick suture that we suture the cervix closed with, and it helps to prevent the cervix from dilating. And we actually leave that really thick, strong suture in place all the way until 36 weeks. So we don't let that cervix dilate at all before then. And then at 36 weeks, they're almost term, we snip it and we pull that suture out and we're like, okay, if you want to go into labor now, that's perfectly fine. But before 36 weeks, we suture that closed so that baby doesn't deliver too soon. Why wouldn't we do a non-stress test for those patients? Well, besides the cervix dilating, it really does not impact the health of the fetus. It won't affect their normal functioning. They should still be healthy otherwise. What you want to monitor with an incompetent cervix is you want to do serial ultrasounds. You want to do ultrasounds to monitor that cervix, and you measure, is it dilating? Is it shortening? Is it showing any signs that that cerclage isn't doing its job? So we monitor them with ultrasound if they have an incompetent cervix. Very good question. I don't think I've had that one before. Oh, you're welcome, Laura. I'm glad you guys are enjoying it. Does anyone else have some final questions for me? Otherwise, I'll let you take off just a little early. Any final questions? You guys have had some great ones today. All right. Well, I've really enjoyed this lecture with you guys. You guys were a great audience. I really appreciate you participating and, you know, doing the answers and everything when I ask. That makes it much more fun to me when you guys are learning along with me. So I really hope you guys got a lot out of this. I know it's a ton of material really, really fast, but hopefully you guys feel a little bit more confident about maternity if that shows up on the NCLEX. So again, very good job. You're welcome, Ruth. I'm happy to show you. You're welcome, Maria. Okay, last one I'm going to do. Someone wants me to show them the ectopic pregnancy slide. I can do that really quick. Boop, boop, boop. There we go. Okay, real quick, ectopic pregnancy. Remember, a normal healthy pregnancy should implant inside the uterus. Ectopic means out of place. So if we have an ectopic pregnancy, the embryo has implanted outside of the uterus. 95% of the time, if I had to come up with an estimation, vast majority of the time, that ectopic is going to be in the fallopian tube. Real quick, why is that? Well, that's actually where the egg is fertilized. A lot of people don't know that. The egg is fertilized in the fallopian tube. The egg is released from the ovary and travels to the fallopian tube. And at the same time, those little sperms are swimming up through the fallopian tube and they meet the egg halfway and fertilize it. But if someone has scarring in their fallopian tubes that prevents the egg, the fertilized egg from getting and implanting to the uterus, you get an ectopic pregnancy. You can also have ectopic pregnancies in the cervix and abdomen as well. And remember, the main symptoms you're going to see, they're going to have a positive pregnancy test, and they're going to have unilateral abdominal pain, usually with vaginal spotting or bleeding. This leads to a loss of appetite, nausea and vomiting, and these are those patients that will faint like that. You know, if that ruptures, they go syncopal. They just faint on you. What do we do with that? We get an ultrasound stat as soon as possible. And if that ultrasound shows us it's about to rupture, they surgically remove it. But remember, what we want to do if we can is we'd rather give methotrexate. Remember, methotrexate is a medication that changes the hormones in the body, and it stops the embryo from being able to grow, and it aborts the fetus. And remember, if someone has an ectopic and they're Rh negative, don't forget to give them their RhoGAM. That's going to be very, very important. Okay. All right. All right. I'm glad you got it this time. Good. All right. Well, again, thank you so much, everyone, for attending. I had a fun time presenting to you guys, and looks like you guys learned a little bit, and that's the whole point of this. So great. Thank you so much for joining. And I hope you have a great rest of your day. Remember, if you're still struggling with maternity, if it just doesn't make sense, you can always watch it on demand. But remember, we always have those one-on-one private tutors who are wonderful. So feel free to work one-on-one too. Oh, I'm so glad, Maria. Good. All right. Well, that is my cue. I'm going to take off now. Again, thank you so much for being a wonderful audience, and I hope to see you all again soon. Bye.